Well, we're going to get started, and presumably, as people hear the microphones on, they'll be migrating back into the room. The next panel is on better health and well-being, and this is a group that's going to integrate essentially what we've heard over the last two panels and focus on what we're all seeking, and that is better health for the American people. It's moderated by McGinnis, who is at the University of Wisconsin, where she's a distinguished professor, a long-time and prominent consumer advocate and founder of the Center for Patient Partnerships there. Joining her on the panel itself are Georges Benjamin, who is the CEO of the American Public Health Association. I think in your 16th year there as the head of it, something like
almost 15.
Yeah, almost 15.
Long time.
And also Molly Coye, who is at AVIA, which is a large health systems network. I think it's termed the largest health systems network focused on digitally oriented transformation of the healthcare system. I may have gotten that partially right. I'm sure Meg will do a better job in doing formal moderating and introductions. And John Dreyzehner is on the panel as well. John is the commissioner of the Tennessee Department of Health and also a leader for a quarter century at the state and local and federal public health community. And Howard Coye is also in the panel. Howard, you'll recall, was one of the editorialists for today's released JAMA series on the VitalDirections. Thank you, Howard, for the time you dedicated to that, and thank you as well for your unprecedented tenure, I think, as the Assistant Secretary for Health in the Department of Health and Human Services and a leader nationally on public health. So thanks to each of you, and Meg, I'll turn it over to you.
Thank you. And now for the panel you've all been waiting for. Because if better health and well-being is not why we're all here, I don't know what is. I'm delighted to be here and delighted to be among the few, the brave of you remaining at the end of the day, and hello to those who are still online persevering, and welcome to these extraordinary panelists. I intend to get out of the way fairly quickly, although the best of intentions is often not met, but I've been asked to say a little bit about what the papers in our section, there are 6 of them, talk about, and to just reflect a moment on cross-cutting themes, both from this particular Better Health and Well-Being section, and also I think across the other papers, since I think there are a lot of cross-cutting themes throughout the 3 sections and the 19 papers. Our papers address systems strategies, so strategies internal to the system to try to achieve better health through life course. There's a paper addressing social determinants of health and health disparities. One addressing preparing for better health and health care for an aging population. A paper addressing chronic disease prevention, including tobacco, physical activity, nutrition. A paper addressing improving access to effective health care for people who have mental health and substance abuse issues. And finally, advancing the health of communities and populations. So again, I think this panel is where it all comes together. What's it all about, Alfie? That's the subtitle of this panel. I find for myself, I'm not a healthcare professional, nor do I play one on TV. I'm a healthcare advocate, and I came to this kind of the hard way. I'm a 22-year metastatic ovarian cancer survivor who was just minding her own business as much as lawyers ever mind their own business in 1994 when I was diagnosed with a life-threatening disease, and I had children who were 3 and 6 months. The ensuing 18-month odyssey gave me a kind of a quick primer on what it was like to be a healthcare consumer in the United States, albeit white, privileged, educated, and well-resourced, and it was hard enough. So that got me kind of interested in trying to help other people and put my law degree to some other purpose, and I guess that's the optic from which I read all these papers and listen to all these panels. So for me, the cross-cutting themes are three. One is, who's doing it? We're fixing a problem without, I think we run into a real problem if we try to fix a problem without partnering with the end users. You've heard this mentioned throughout the day from time to time, but I want to be sure to underscore, you get what you pay for. And it is expensive because we don't really know much about engaging across the various end user populations. We don't know very much about it. We don't know very much about how to be effective. And it's foreign territory, but it is something we need to do, because if we don't, then we're solving problems we think we understand with solutions that we think might work. There is an army of untapped patients and family with real skin in the game, but there's a big challenge, and we've heard it today all day, and the challenge is trust. Who decides? And it seems to me that the interesting conversation we had in the first panel about the tension between public and private, as a patient and an advocate, in some ways that conversation to me is presented as which do I mistrust the least, the public or the private sector in this discussion? And that's, I think, not an uncommon dynamic. We see it, I think, in the electoral politics in the United States today, and I think it applies here as well. So the second one is, what should we do? Should we tinker or should we revamp? What are the parameters of our redesign project? Would we balk, for instance, I was thinking in the last session, would we balk at the notion that the government would provide smartphones to everyone as a basic tool to enhance health, to enhance access to health care? It certainly would be cheaper than a moonshot. And we had the resources to do that once. So the answer to this question may depend in part on how the current system is working for me and the people I care about, and how much we can get outside of me and the people I care about, I think. How selfless, in a sense, we can become. And the third question that I see, this third sort of overarching theme, is how will we know? This big question of data and measurement and interoperability, will we be able to collaborate? Will we be able to share what we know? Will we be able to actually gather what we already have and know and put it to purpose without notions of ownership, ego, profitability, or other concerns eclipsing our drive to do what we know must be done and what we know is ethical and kind? So for me, those are kind of the overarching things. Who's doing what? What should we do? And how will we know that what we set off to do makes sense, that it's the right thing to set off to do? So that's my little 2 cents worth. As my panel's already been introduced, I'll start here with Molly. I'm going to ask each of you to answer the question, what are the most important common themes and priorities in the discussion papers?
Okay, well, this is really a great panel, and I look forward to what the rest of the panel will say too. I would say that I saw 3 things that I thought of wanting to comment on. The first one is, in a sense, that we are very much waking up to how badly we have essentially committed the Winston Churchill mistake. You remember he accused Americans of trying everything that doesn't work until finally they give up and try the thing that does. We have been fixing and tinkering with the health care services, with the health care system, for a very long time, even as the evidence mounted that social determinants of health were really very important. Mike McGinnis's paper is quoted regularly, but honored in what is it, in absentia? That's not the right phrase to use here, but basically our policies have not caught up with what we know, and our budgets have not caught up with what we know. And I think that if you looked across all of the discussion papers, including those in health and well-being, you see this profound sense of let's be intellectually very direct. Let's really recognize the fact that we need, I believe, a very fundamental shift in this. And Mark McClellan's slide this morning showing the difference in distribution of expenditures on medical care versus social support is, I think, something that is going to stick in people's minds as a way of portraying this. So we know that this approach has not worked. And as we start to talk specifically this afternoon about how to achieve health and well-being, and as we go forward developing new policies in that area, I think we should keep the Winston Churchill mistake in mind, because we could commit it all over again in health and well-being. We could fail to follow the evidence and not innovate with rapid testing to see whether it's actually working. In each of the discussion papers on health and well-being, though, we saw confirmed that we do know enough about what works to take action now, to really change our policies now. So I would put my emphasis a little differently. We will always, and all of the papers called for investing in further technology development, research, workforce development, all of those should go on, but we don't want to wait for those in order to start changing our policies. We know enough to act now. I would add to this particular point that we should also remember that the 80-20 rule that we've become very familiar with in population health, we think in terms of 20% of the people produce 80% of the costs, that the same sense of distribution, unequal distribution of burden exists in health and well-being, and we should make sure that our policies address disparities of every kind, and that we go for where we can really make a difference and use the tools that make the most difference. I can say also that even though this morning's first panel commented on how we don't know the effects of some of the policies we would like to implement, that many of the people here are in government leadership positions or have been. And I led the health department in New Jersey when we were doing DRGs, following up on the implementation of that, and in California when we did Medicaid managed care. There is no way to anticipate all of the adverse effects of each new policy as you roll it out. You do your best, but you have to keep moving forward and follow the evidence and do the things that are most likely to work. So I would strongly support the idea that we do need to link knowledge to action. If I can just add two quicker points. The second one is that in most of the papers you will see a strong suggestion or recommendation that technology be deployed against all of these social and behavioral factors that we're going to talk about here in health and well-being, to support prevention and early, less expensive care for people and communities. And Peter Orszag's comment this morning about place-based care is really the unification of population health and community and regional public health. The most useful technologies, to reassure you, are often combinations of big data and small technologies. Small technologies are communications and information technologies that allow you to reach and support both individuals and groups in the community to improve their behavioral change, to track community patterns, and to aggregate information to allow you to learn more rapidly what's working and move forward with iterations of your policies. To do this, we need to remove regulatory and payment barriers, and this was called out in several of the papers, in order to enable telehealth, telemedicine, and other technologies. And I, interestingly, had come up also with this suggestion. To extend this, we should also consider situations like seniors lacking social engagement and physical movement, in which devices like smartphones and monitors could be considered health, not medical benefits, and health devices, and therefore covered by private and public health plans. So we know that some Medicaid managed care plans have experimented with that. So I think there's a lot to do in that area. And finally, the last point is that many of the discussion papers pointed out that workforce solutions for health and well-being, for social determinants of health, for mental health, for aging, health across the lifespan, really go to a very different cadre of workers. Community health workers, social workers, and including licensed mental health social workers, family caregivers supported with payment and education, and peer communities. These types of workers have already been shown in multiple studies to be highly effective, low cost, and readily available in the communities they serve. Solving this problem and growing this new workforce is a new form of a Jobs Act, a way to bring entry and early career jobs to underserved communities while meeting the need for cost-effective care with high patient satisfaction and solid outcomes. So those were my three, and I'm eager to hear.
I'm up.
You're up. What are your themes? Don't get into advising me yet, because Elias really informed me about how to act presidential later. I'm going to do that later.
So let me just answer the question that you asked,
Yep.
and that's I think revamp. We have to revamp.
Oh, good.
I think in many ways we've been having the wrong conversation for a long time, and I think it kind of starts with what our answer to the question is, what do we want for our children and our grandchildren? Do we want them to have access to health care with the hope of well-being, or do we want them to have health and well-being itself? Is what we're really after health or merely access? And when I think about all of the tremendous thoughts in the papers that we have now the opportunity to look at, and as a sitting state health official myself and a physician, there is a lot there, and I recognize I've got a lot to do. But in order to kind of begin to take a bite at that, I kind of have to think of, well, how am I going to frame those things in order to create a vision and a methodology whereby we can begin to do that. Because when we talk about health and well-being or health and prosperity itself, we're talking about potentially goring some oxes that already exist. We have this sick care system that's incentivized to do really well exactly what it's doing. So I think when I think about framing questions, I have 5 of them. Are we fostering or creating opportunities for continuous improvement in health to create health equity and optimal health for all? Because that's what I think we really want. That's what we're really about trying to get. And for many, many years, we've thought the path to that was through healthcare, and the evidence is that that's not the case. In fact, I think the evidence is we can't treat our way to good health. We're going to have to go towards prevention. I think in that context of that question, we're talking about the resources and environments that strongly nudge us towards healthy behaviors. And equally important, eliminating stigma. Because when we're talking about optimal health for all, and we recognize what's in the way of that, those are the things that Dr. McGinnis described really well in his paper years ago, those health behaviors. And in our state, we talk about the big 4, physical inactivity, excessive caloric intake, tobacco and nicotine addiction, and other substance use disorders. And we recognize that those are driving almost all of our morbidity and mortality. And in this context, we're talking about 7 of the 10 leading causes of death, and 85% of our cost, and not unimportantly, 50% of the cost being driven by just 5% of us. So, second question: are we moving upstream? It's primary prevention and not secondary and tertiary prevention that is the path to population health and optimal health for all. I'll call that OFA, optimal health for all. I think we have to, in moving upstream, we kind of have to end the insanity of new entrants to nicotine addiction. That should just be something that as a society we find unacceptable. I also think we have to not discount the downside risk of other addictions like sugar, like opioids, and I'm increasingly worried about the conversation around THC in our nation. I recognize it's controversial. Alcohol and other addictions certainly as well. I think we have to fully recognize, and this is on the positive side now, what do we do about this? I think we have to fully recognize, in terms of moving upstream, the incredible power of physical activity. Physical activity, if we could bottle it, I think would be a wonder drug. I think it's an engineering control for the human body. And I think we have to think about things like implementation of the National Physical Activity Plan and the Comprehensive School Physical Activity Model. From a health and nutrition standpoint, I think we have to begin seeing food as medicine. I recognize its joy. I love food. I'm a foodie. But food has to be thought of as medicine and not just a choice and not just nutrition. Third, are we learning from or teaching others? So that gets into the whole conversation from the last panel. Evidence, best practices, where evidence doesn't exist. As a physician for the population in Tennessee, sometimes I have to use judgment where evidence or best practice or principle don't exist. But generally we can combine all those in the decisions that we make. Fourth, do we have a common systems approach and a framework to put this all together? There are a lot of frameworks out there. I think one model that's been recently proposed by Cap et al. Is the Baldrige framework for performance excellence. We use it in my department. I know a lot of healthcare organizations use it. I think it's a potential way to bring all these disparate things together and to create more systemness, which I think is a word that I first heard John use, and we talked about that in the last panel. And I think what Baldrige forces you to do is ask the question, who are our customers? And I think we have to be honest about who our customers are, because clearly our customers right now in the healthcare space aren't patients. None of us are really customers. At best, we're beneficiaries or end users, but we're not really customers. And in order to start making changes in the way our system works, we have to start thinking about patients as customers, and we have to start incentivizing our systems to treat patients as customers. And a big way to do that is put patients in the driver's seat. And then finally, how do we know if we're successful? How do we know if it's working? And our incentives align. So I think vital signs is a really important piece of that. We're working in my state right now to define population health and what are the components of that in our context and what are our vital signs. And here's the other kind of really important piece of that alignment. Somebody wrote a paper a long time ago about hoping for A and rewarding for B. And I think we really have to think about that in the context of our own health and well-being. If we're hoping for health and rewarding for care, we're going to get care. If we're hoping for health and figuring out how to reward for health, then there's a path forward. And all that in the context of recognizing in some ways we're talking about trying to fix the airplane as we're flying through the air.
Right.
Not easy, but I think we have to start with those framing questions.
Thank you, John. Howard?
So, Meg, thank you for chairing this, and I want to start by thanking Victor Zhao, Mike McGinnis, and Mark McClellan for coordinating today. And as Mike mentioned, I also had the incredible privilege of reviewing all 19 JAMA viewpoints and writing an editorial for JAMA. So I want to thank JAMA and Dr. Howard Blockner, the editor-in-chief, for that extraordinary experience. So I'm a physician who's cared for patients for over 30 years, a former state commissioner of public health in Massachusetts, and as you heard, the former U.S. Assistant Secretary for Health. So like all of you, I've thought about health just my whole professional life. We haven't heard a definition of health yet, but my favorite one, far and away, is the 1948 WHO definition of health, which reads that health is, quote, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, quote, unquote. I love that definition so much, I'll say it again. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And if I had to summarize what VitalDirections has done in one line, it's gotten all the suggestions closer to what the WHO definition of health first proposed in 1948, because it means that health is more than just issues of the body, but also the mind and the spirit. It's about communities as well as individuals, and it's not just about absence of disease or infirmity, but it's about complete well-being. Now here's the irony. Some of us need health care some of the time, but all of us need health and well-being all the time. And despite that reality, when you talk about prevention and well-being, those discussions are usually undervalued, underappreciated, underfunded, and overlooked. And if I had to summarize in one line, a theme for the next administration is that has to change. We have to talk about health and well-being and prevention just as much as we talk about healthcare and system performance and other issues that have to do with treatment. A couple themes that have not been mentioned explicitly about the environment in which we're working is that the demographics of this country is changing rapidly. First, we are an aging population. I have some colleagues, Terry Fulmer and others in the audience, who have written about this. One line in the VitalDirections on aging is that every year, some 3 million people reach the end of their lives, and are we prepared to deliver care and quality of life services to that population well? Also, racially and ethnically, we are getting more diverse by the day. Many of you probably know there are projections that by 2043 or sooner, this country will be a majority-minority country. I think about that a lot as a son of Korean immigrants. And then you can talk about diversity in terms of sexual orientation, by level of disability, by geography, by educational background. So these are all issues that complicate trying to bring health and well-being to everybody in this rapidly diverse society. But I think it drives the conversation about moving toward not just patient-centered conversations, but person-centered conversations, and then ultimately population-centered populations. And then this segues into the disparities and health equities themes that have been mentioned several times now today, starting with the slide that Mark showed this morning from Chetty's piece showing how much income affects health and how that social determinant is such a huge driver of health outcomes. So what can we do about it? I think talking more about respecting the social determinants of health and bringing social determinants of health approaches into the future of health discussions is absolutely critical. I like to say that health starts where people live, labor, learn, play, and pray. I made that up, so I'll say it again. Health starts where people live, labor, learn, play, and pray. So what does that mean? I think for meetings like this in the future, in addition to having health experts, we need experts from transportation, from housing, from education, from business. And we in the health world have to stretch and join hands with leaders in other parts of society to move health forward, and there are many ways to do that. I'll be saying more about that in our second round of comments. But the social determinants of health approach is absolutely key to our future, because that's what's driving most of the health outcomes that we see right now. The prevention theme is so hugely important, so let's start with tobacco. Why are we still tolerating a condition that's killing nearly 500,000 people a year in the United States? We have made great progress on tobacco control, but it's not nearly enough. We still have 17% adult smoking prevalence. We need to drive that number down to 0. For example, in my classes that I teach now back at Harvard, where I'm a professor, I ask my students, what's the leading cause of cancer death in men and women in our country? And the answer is lung cancer, which is mostly preventable. Lung cancer should be an uncommon cancer, not the leading cause of cancer death in our country. So it's simple facts like that that really drive the importance of prevention and wellness home. And then you can talk about that theme with respect to obesity. Pandemics we haven't talked about today, old and new, whether it's flu or Ebola or currently Zika. Global warming, we've had this unique, unprecedented Paris Agreement in 2015 where almost all countries signed that agreement. Now we're waiting for formal ratification. That's going to have a huge impact on health and wellness in the future. And then a final theme that has not been mentioned but is critically important, actually John talked about it a little bit, is integrating mental health services with the rest of the healthcare system and substance use disorder services. That's been separate and unequal for far too long, and we need to talk about bringing those back together again as part of a person-centered, patient-centered, population-centered approach. We, in the future, also need to talk about how to keep all this alive through funding. The Affordable Care Act has tried and has met with some mixed success. And now there are efforts to integrate prevention more into alternative payment models like ACOs, so we can talk more about that. So these are some of the themes I think we can all flesh out together as we make health and well-being really, truly the focus for the future. Thank you.
Thank you, Howard. Georges?
Yeah, you know, at the end of the day, at the street level, the average citizen needs to understand what we're talking about. And what we're talking about is living as long as you can, as well as you can. And we know very clearly that in order to do that, we have to go way upstream. It turns out, magically, much to our surprise, that we actually have a system and infrastructure that is there to do that. It's called your governmental public health system and your non-governmental public health organizations, a range of private sector groups that do that, as well as the private work of our health care delivery system through things like the community benefit work that they do, and many other community activities. And at the end of the day, we want to change and transform our health care non-system to a health system. And that requires, and the papers talked about, fundamentally leadership. That means having leadership at the national level and then, of course, at the local level, which drives us in a particular direction to say, as a nation, we are going to, as a national objective, be as healthy as we can, as well as we can, and aligning and using all the tools in our tool belt to align the resources to get us there, both system-wise, fiscally, et cetera. And then, of course, with that leadership, then investing in a deliberate, intentional way, and more importantly, in a sustainable way, to rebuild that system. So that means, once and for all, deciding what the mission of governmental public health ought to be, and adequately resourcing it, and more importantly, sustaining those resources. Because far too often what happens, we do is what I call yo-yo funding, where we put the money in when something bad happens, and then as soon as it goes away, we pull the resources back. But interestingly enough, the expectation is still there, that we have the capacity to continue to go forward. The second thing, of course, is leveraging across silos, using health and all policies approaches to leverage what other groups do, whether it's the local sheriff who has decided that they want to decompress their jail because they recognize that they are the largest mental health provider in the county, and looking at diversion programs for people with mental illness so they don't have to be in their jail. Whether it's the planning folks in the community that decide that they are going to work with the builders in their community to build those communities so they're walkable, bikeable, and green. Where the hospital system works with the local health department to look at their community needs and actually focus all their resources in the right way. So the papers collectively talk about really rebalancing our portfolio in a way that builds a comprehensive health system that focuses fundamentally on wellness, but does not skip on things when you crash your Chevy. We still are able to put you back together better than you were before.
Wow. All right. Thank you. I think that sort of answers everything, doesn't it? I mean. As I said, Elias taught me how to be presidential. So I'm going to be presidential here. And for one...
Our first woman president.
Just yours, ma'am.
And I will be our first woman president. And I'm going to ask you the question, if you had 5 minutes with the next president and his or her advisors, well, in my case, her advisors, what are the priority issues and related actionable steps that you would highlight? And I will add that you heard me say that I'm really kind of on the fence about whether just to throw the whole thing out and maybe pick up George's suggestion that we have an old and somewhat dramatically underfunded public health system. Why shouldn't I just pull all the 18% GDP that we're spending out of the health care system and put it all into the public health system, and tell me why I need still to fund health care at all? And, what should we do dramatically if we were going to plan a moonshot in health care? So I want to shake it up as the president.
We're going the same order.
Oh, maybe we should go the reverse order. All right, Georges, you get to go first.
Yeah, I'm pretty simple. We spent the last 8 years doing healthcare insurance reform. I would spend the next 8 years, Madam President, on doing public health reform. And when I define public health reform, I'm thinking of looking at things from a population perspective, building the systems, letting our data drive the systems in a much more coherent way than we do today, and beginning to align our systems in a way that gives us the value that we want, the value that we inspire for. And the interesting thing is we actually know how to do this. We pretend like we don't. We have enormous measurements. I mean, we've got state health rankings, county health rankings, and yet we put our heads in the sand to do things that we know work. And then we also know what we don't know. And that's the more interesting thing. And we ought to put the money there in things of like health systems reform. ARC has been totally underfunded for the research that they do. And yet, when the VA got whacked over, frankly, the appointment schedules and times, when the IOM actually looked at it, I guess now National Academy of Medicine, Victor, it turns out that nobody has any good measures on appointing. Shouldn't we study that? Because everything is derivative on how many times you see a patient. So those are the kinds of things that we know what we know, and we know that what we don't know. And we also, of course, don't know what we don't know. But the point is that
starting to sound like the former Secretary of Defense, I think.
I do sound a little bit like him. But the point is that at least on that he was right. But again, it requires us to say, that's what we want to do, that's where we will put our resources and our time, and that requires leadership at the highest level to do. So that's what I would tell you, Madam President.
So the first bill that you draft for me, what's it going to contain? What 2 or 3 things is it going to contain?
Oh, I would absolutely fund the looking at and coming to some consensus around what our resources need to be for population health. And how we align them. If we had a white sheet of paper, how would we design a system to get us there? And then I would literally take every part of the federal government and our resources to nudge the system, but aggressively in that direction.
Okay, thank you. Howard?
So I have some concrete suggestions to offer to the next president. First, we have to make the social determinants of health approach come alive. So that means more explicit conversations about the roles of housing, early education, home visiting, earned income tax credit, those sorts of themes, and link it to health outcomes. The health in all policies theme has been mentioned by Georges and is mentioned by Lynn Goldman and her colleagues in one of the chapters. Can we make that come alive throughout government? That would be very, very exciting. And by the way, when we talk about the social determinants of health approach, so much of this depends on having the leader bringing representatives from those various sectors of society together. So I've experienced this a number of times in government. One of the honors I had as Assistant Secretary is overseeing the Healthy People 2020 process, which Mike McGinnis actually helped launch a number of years ago. And when we set out goals for the nation over the next decade, we not only had health leaders, but people from education and housing and transportation all there, so that we were talking across boundaries, if you will. And I think the more you do that and do that routinely, the better off we're going to be. We're in an era where we can talk about the end game for tobacco. We can raise the legal age of access to 21, as was suggested by Bill Dietz's group in the VitalDirections report. And we also now have FDA authority to regulate tobacco for the first time since 2009. And the tobacco industry has always said they don't want to addict anybody. They just want to have customers choose brands that they like. And there was critical research published last year showing what happens to behavior of smokers when the nicotine levels in cigarettes are reduced very low down to non-addictive levels. And it showed that people increased their quit rates, decreased their nicotine exposure, and really tried to use that as an opportunity to improve cessation. So can we get to a point in the next administration where an end game is seen for tobacco and the FDA can explore its potential authority to allow so-called non-addictive cigarettes onto the market? That's a fascinating, very, very important cutting-edge conversation, but I think we should have that going forward. For obesity, we all got to see in 2010 what happened when the Healthy Hunger-Free Kids Act was passed. So this improved nutritional standards for some 22 million kids in the school lunch program and the school breakfast program. So that needs to be reauthorized. Meanwhile, the Every Student Succeeds Act was reauthorized in 2015, giving educators more access to funding for physical activity resources, potentially. So that's an advance. For mental health and substance use disorders, we had a critically important 2008 Mental Health Parity and Equity Addiction Equity Act, MAPIA, terrible acronym, by the way. And that requires that payments for mental health and substance use disorders be on parity to what's seen with other physical disorders, and rules were finalized for this in 2012. But implementation of this is not going as smoothly as people would like. If we're really going to break down stigma and get people into services for substance use disorders, we really need to make MAPIA go even stronger going forward. We've had some discussions today about leveraging science, the Brain Initiative, and precision medicine. And the promise of that is very tantalizing, but we also have to be sure that that research advances population health as well as saving individual lives. Actually, Dr. Zhao had a very thoughtful piece on that as one of the viewpoints. We need to invite in people from law and ethics and public health to join the basic scientists and make sure that this life-saving revolution is used to help individuals as well as populations. General theme throughout all the viewpoints and throughout all of VitalDirections is just integrating efforts. And right now we talk about healthcare over here and prevention over here and well-being over here. Can we put that whole discussion together because we want to make all people move toward a complete state of well-being? That's what the WHO definition is all about.
It sounds like a lot of public action, a lot of governmental action. And there was a criticism this morning or this afternoon in one of those panels that the problem with government action is that once it's done, it's very clunky, and you can't sort of move around inside it, and you can't make quick changes, and it's very, takes a long time, and then it gets stuck.
Well, that's right, but it doesn't have to be governmental action. You have to have governmental leadership, and that can be the types of things the Surgeon General does, the bully pulpit, and allowing people to do things, and getting rid of regulations that allow people to have more flexibility. But it doesn't have to be governmental. A hospital can decide that they are going to use their government relations activity to go into the legislature and support the tobacco efforts.
Yes,
Putting more sidewalks, showing up, the hospital showing up at a zoning hearing to build sidewalks in a community. So it doesn't have to be governmental at all.
Okay, all right. John?
And I think the good news, Madam President, is your advisors are largely in agreement with what needs to be done. And I think we also probably have some understanding of the daunting task of changing the way we incentivize. Because at the end of the day, if we want to get to health, we're going to have to figure out a way to reward for it, and not just rewarding the healthcare system for health and expecting that they deliver it, but kind of rewarding ourselves for health. And if that was easy, if it was easy to for us as individuals to just want to do what we love to do and be with who we love to be with, and to, as Georgia said, live and do those things as long as we could. Those things were easy. We wouldn't have the problems with taking in excess sugar or nicotine addiction or opioid addiction. We wouldn't have these things that attract us, that hijack our reward system and fool us to where we discount the downside risk of all the things that are going to end up happening as a result of those behaviors. And then we discount the downside risk, and in the back of our minds we think, well, if it happens to me, then healthcare will be there to fix me and save me and get me back to health. But we recognize that's not really what's happening. If in fact that 17+% of GDP was buying us health and well-being to the degree we think it should, then maybe that would be worth it. But it's not. So I think I would ask you what you want your vision to be. Is your vision for access for all? And we all need access at some point, but is it that you really want your children and your children's children to have health and to have it abundantly? And it's not a zero-sum game. We can have it all, but it's not easy to do, and we have to change some of our systems to make that happen. So moving upstream in all we do is critically important. Those drivers of disease, that big four that I mentioned, and I'll say those things again, and you could say them different ways. I like to say physical inactivity and excessive caloric intake and tobacco and nicotine addiction and other substance use disorders, because it reminds me that they're not separate and distinct entities. And this is really important because most of us think of those things as unlinked. But they're all linked in here because we've got this reward system that wants those things to some degree, and that can get hijacked by it, our dopaminergic reward system. And it's not important for people on the ground to really know that, but it's kind of important for policymakers to know that and to understand that if we don't move beyond the stigma for some of the end results of those behaviors, we're never really going to be able to get to permission for actions to occur in our communities where they really need to occur for us to nudge ourselves in a healthy direction. And we have examples of how we've done that before. We remember from the 80s. You may have been around in the 80s, Madam President, and you may remember HIV/AIDS.
If you remember the 80s, you didn't live through it. No. That's the 60s, I forgot.
That's the 60s, right. And you may remember how stigmatizing that was. Even in the public health community at the time, people were worried about treating that population.
Right.
And I think by and large that's kind of gone away now. So I think we have to realize that those are the things that get in the way of the fulfillment of our human potential, and we're all vulnerable to them because we're all here. If we didn't have that reward system, evolutionarily, we wouldn't survive. Speaking of evolution, I think we need to remember, Madam President, our evolutionary biology and pay more attention to it. So in some of the papers, we're talking about things like breastfeeding and the importance of, when possible, a term vaginal delivery, and all the things that go along with that in terms of the microbiome. We also have to think about sleep and sleep cycles, and not ignoring that. And we also have to think about those things that have kind of gotten in the way, our modern living, that are interfering with those very basic things that we've evolved to be able to take full advantage of. And that gets into things like, even primordial prevention. What do we do with mom and dad before there's baby? And from a healthcare standpoint, that's really extending the episode of care. And how far can we extend that episode of care reasonably? And what can we hold ourselves as healthcare providers accountable for? I don't think all of it. Some of it has to come from the community. And I think those things are critically important. The other thing I would want to plug is we have to create more of a system of health, and we're going to have to think of a way to tie that together. One of your predecessors, called the Great Communicator, put forward a system that eventually got named after his Commerce Secretary, Malcolm Baldrige, because he passed away in office, the Baldrige Framework. it's a framework. It's a way of thinking about things, and it can be applied to I think a lot of different sectors. It's time maybe that's not the one, but it's time that we deliberately, and this is where I think governmental leadership can be helpful, it's time that we create a framework for the system that we want. And like the great communicator, I would think that you might want to pay attention to some of your evolutionary drives and maybe consider taking a nap from time to time, because you've got a really hard job, and it's tough. And these are all easy says and difficult do's. But at the end of the day, we have to push back against the big four. We have to take back control of our lives and our health. That happens at the community. And let me leave you with one other thing in terms of what the media is talking about in your campaign, or what they talked about in your campaign. They weren't concerned about whether or not you could see a doctor. They were concerned about whether you were healthy enough to do the job.
Indeed. Thank you.
Well, Madam President, first of all, it's an honor to speak to the first woman president. And so I have three things I'd like to pitch you on. The first is, like many of my colleagues, I would like to see a redirection of efforts and leadership and funding. As a matter of fact, I'd like to ask you to mandate a sweeping redirection of healthcare policy and spending to tackle the social factors and behavioral factors that are the actual determinants of health. I would characterize it, however, as not pulling the majority of the money out of health care, not just for political reasons, but because I think that we have an absolutely useful middle ground here when an entity takes responsibility for the health of a population with capitation, with a budget for that population. If we hold them accountable, not just for the medical care services, but the health status of the population. And increasingly, as you look at the proportion of the population that comes under a risk-based contract of some kind, a community becomes a sum of these. That will, I don't know how we could right now say, oh, that represents 40% perhaps, or 50% of where we would need to get to. There still needs to be money redirected specifically into the cross-sectoral and public health efforts, so public and private public health, and recognizing that if much of this is happening in housing, in education, in the justice system, in many other sectors, that you don't get there just by putting it in the public health system per se. It has to be distributed in collaboratives, essentially, or whatever the appropriate language is going to be for this. But the key thing here is accountability, because many of the interventions around, for example, nutrition and housing, show huge improvements in terms of healthcare expenditures within 24 months. So it's not an impossible cycle to build where you start to make the money shift flow more quickly as you start to get traction using the tools that we know actually work. So risk is not a one-stop solution, but it's a framework that allows the public health, governmental and private, and the care services world to look together at the data, at the responsibility, at the effectiveness of interventions, and continue to innovate where it's needed and research as they go forward. Now, I think that this will move a lot of dollars into the community, into prevention, and into home and community-based models of care. I'm seeing that happen in population health in both the private sector and the public sector. And in fact, the single greatest impact of an innovation that I've seen cuts across all of these, and that's the in-home palliative care model, initially developed by Kaiser Permanente, published in the early 2000s, and still probably the most effective innovation to date. It shifts care from the hospital and physician's office to the home, including family and caregivers as well as the member or patient, and saves approximately 30 to 37% of net cost in the last year of life, with huge patient satisfaction, and it uses the licensed social workers and other types of community health workers with nurses and physicians as guides and consultants. So it's a very good example of how you can see real innovation and shifting with tremendous generation of savings that then can be used for food programs and for all of the other public health purposes. So you'll see in the papers many examples, as some of my colleagues have supported specific programs that you would want to spend the money on. But I would say that secondly, the second recommendation I would like to make is that there's been this tremendous growth in public awareness around the need for coverage and programs in mental health, and the Parity Act and important legislation to move us forward on that. So seize the moment, because mental health is really the canary in the coal mine for healthcare. It's the perfect place to see how the social determinants and the capabilities of the governmental system of public health, which is grossly underfunded and understaffed now, and healthcare services in which mental health has been frozen out in many ways and really had a lot of difficulty fighting its way into the clinical healthcare system, to see how we're doing on integrating all of that, using our resources wisely. It really is it's important in its own right, of course, but it also is the place where we really ought to focus a lot of resources now. And lastly, having been a state commissioner in 2 states, I would want to stress again, remember the states are the laboratories. So many good things are done in the states and die on the vine, are never brought to fruition. So form a task force and send them out across the country. Don't just look state by state, also go and look at health systems, look at public health and community collaboratives, and find the best models. In Massachusetts, their Health Policy Commission, which, as George pointed out, they did their health reform 4 years earlier. So they saw the limitations as well as the benefits of it earlier. So they then put together a Health Policy Commission. I don't know whether you're a part of the people to blame for this, Howard, but it's been very, very effective. And they put together an innovation fund, and this summer they released $10 million in incentives for health systems and community partners. Average applicant had 4 partners, to implement programs that were already known to be effective. So this was not go out and invent. This was, we know there are programs out there, and the vast number of program applications came back in social determinants of health, behavioral health, community collaboratives around underserved populations, end-of-life care. So I really think that there's a great desire to solve these problems if the right opportunities and incentives are put forth. So I think you could really fire the imagination of the country by putting out a call for that kind of, what are the effective models, let's put money behind them.
You also have a model within government that can be used, the Public Health Prevention Council, which of course is designed to cross sectors, and really paying a lot more attention to that than we've paid in the future, and actually, engaging at the cabinet level cross-sector activities that can really leverage the health and all policies approach, that can leverage spending federal dollars to addressing policies across government, and in many ways giving locals the flexibility to do that Molly talks about, to do that laboratory of innovation that occurs through the way that we incentivize both federal programs, federal dollars, and the flexibility that we currently give states and localities to do this kind of work.
Well, turning now to the brilliant folks in the audience and online, I'm wondering what your thoughts or questions or hates, hopes, loves, and fears might be at this moment listening to these extraordinary people with extraordinary experience talk about their visions. While you're summoning up your courage, there's a question that
You're so intimidating.
keeps spinning in my head, which is, you know, ought there to be, on the frame of Howard's comments about the importance of making sure that all the different dimensions of life are at the table, ought there to be an Uber cabinet position that kind of addresses the crisis of 18% of GDP going to health, with 12% of that having anything to do with, I mean, with the part of the healthcare having no more than 12% of impact on total overall health, right? Healthcare is only, what, 12% of determinant of actual overall health, I think, is found in healthcare. 18% of GDP going there. And well, why are we still meeting with the Secretary of Transportation and a Secretary of Housing and a Secretary of Education when really it's all kind of, should we be thinking in some sort of broader?
Well, there's an opportunity for the Domestic Policy Council to advise us to the President, obviously, and do that. But again, that's why I said it requires leadership, you know. Yeah. I mean, frankly, you know, when we did the Affordable Care Act, we made with intention that our national goal was to get as many people covered as we could. Now, we still need to do that, because I don't believe you can have an effective system unless you have one with everyone in and nobody out. But having said that, it's very clear that the Obama administration worked very hard to align their resources. You know, Howard was in the room when they did this, but to make sure they did this by using every lever of government to try to make that happen, and then to try to incentivize the private sector in a variety of ways to make that happen. Why we can do that to the broader population health. That also means when we get successful models, I think you heard the question asked in the last panel, of people that are able to effectively utilize and engage the social determinants as part of their practices. One of the things as a nation we don't do very well is rapidly disseminate that information and then allow people to customize that so that they can maximize that at their local community. And that requires, you know, some effort, and again, with intention to do that. Now, CMS is trying to do that to some degree with their MMI models, their population health models, but we need more of that to make that happen, and that's happened much faster.
Right.
Meg, your point is an interesting one, because of course we have the Health and Human Services Secretary in the Cabinet, and then the Domestic Policy Council, as George has mentioned. There is an Office of National AIDS Policy, the so-called AIDS czar, and that's been established for quite a while, so that comes out of the White House. And then there's a White House Office of National Drug Control Policy. Michael Botticelli, my dear colleague and friend, doing a wonderful job as the so-called drug czar. But is there an opportunity to look at those structures a little bit differently and have something more cross-cutting in the next administration? That might be worth talking about.
And might be responsive to some of the trust issues that I was raising, however inarticulately, you know, that as a kind of a end user and a consumer and a taxpayer, you know, my question is not, would you spend 18% of GDP? I guess I would, because we are. So I haven't run to some other country yet. But boy, I'd sure like to spend it more in the way you folks are talking about than in the way we are currently spending it. And that desire on my part, that motivation, is actually remarkably valuable, I think, in terms of pushing this agenda forward, or could be remarkably valuable. If we tapped that kind of frustration we're seeing tapped and we're seeing explode and say, yeah, we hear you, we agree, and here's how it could go differently. The question is how to use that army of...
That's right, and not get in the way of local innovation. so that we create barriers for the private sector to do this. I mean, you know, at the end of the day, form follows finance. And to the extent that we can get those incentives aligned appropriately, and then unleash the private sector to be able to do that, then you'll get that innovation.
Not only arguably not get in the way, but arguably create much more robust, interesting, and diverse community engagement in the process at all. And then there will be even more of those.
That's right. And get, you know, by the end of the day, the consumer has to demand this. So that means price transparency. That means, you know, some 22-year-old has got to come up with the magic app that creates the innovation that's disruptive to move our health system along as well.
And it has a phone now because Molly and I got one for him out of the, you know, that's my first presidential act, is to get everybody a smartphone and broadband.